Hello everyone, it's my great pleasure to be here with you. My presentation will be risk management of unresponsive endophthalmitis using intraocular povidone iodine, a case-based experience. I am Omer Abdullah from Erbil, Iraq. Background: acute infectious endophthalmitis, a vision-threatening emergency. Visual recovery depends on speed of diagnosis and prompt management. But in spite of standard care, there may be a subset remains refractory cases. The clinical challenges of unresponsive endophthalmitis could be due to high initial inoculum or virulent organism, delayed presentation, sequestrated infection, suboptimal antibiotic penetration, fungal or polymicrobial infection. In this case, escalation strategies are not clearly standardized once conventional therapy fails. Why consider povidone iodine intraocularly? Because it's broad-spectrum antimicrobial, rapid action, onset of action, no classical antimicrobial resistance, and there are published literature supporting low dose of povidone iodine for endophthalmitis. Regarding case presentation, case number one, 58-year-old female diabetic, after removal of corneal stitches, 3 hours later developed pain and blurred of vision. Had been treated elsewhere with 3 successive intravitreal injections and without any improvement. Knowing that povidone iodine could assist, we managed the case. The anterior chamber thoroughly irrigated, cleaned from debris, followed by standard pars-plana vitrectomy with a low dose of iodine in the infusion cannula. But the outcome was unsatisfactory. The visual acuity and the IOP was the same. Regarding case 2, a 63-year-old male diabetic presented with endogenous endophthalmitis and 2 doses elsewhere had been given. Given the previous lesson, we searched for more recent publications. We found that there's low dose combined with low dose antibiotics. For this case, the surgery commenced with meticulous irrigation of anterior chamber to decrease the microbial load and have a good visual system. Meticulous, careful pars-plana vitrectomy performed with low dose of intravitreal iodine, but the result was also unsatisfactory. Here, I would like to attract your attention to our case. The third case, a 54-year-old female diabetic, at the fifth post-operative day of uneventful phaco than elsewhere, presented with pain and blur, had been treated with drops for 2 weeks. Then, when they realized that this is endophthalmitis, 2 sessions of intravitreal antibiotics given without any improvement and prepared for the third dose. When she came with us with the active endophthalmitis VA of LP, we fully discussed the situation and the previous recorded cases, what happened with them, full informed consent taken with the patient, and a rescue technique invented, and controlled intraocular with controlled intraocular exposure to 10%, povidone iodine exposure time less than 1 minute, immediate thorough irrigation of the given material. The aim was rapid intraocular sterilization followed by immediate dilution and removal. The surgery here commenced with meticulous IC clearing from fibrous exudate followed by anterior vitrectomy, then core vitrectomy started. All over the retina was covered with dense membranes, whether due to fibrous exudate or due to diabetic membranes or due to combined exudates and diabetic retinopathy. Meticulous care taken to remove all these membranes in friable retina without inducing any atherogenic tears. Also followed by removal of epiretinal membrane carefully Then all materials, debris taken and shaving performed, followed by injecting of a small amount of 10% of povidone iodine, 10% with immediate irrigation up to 1 minute till the media became cleared. In the first postoperative day, we face it a brownish exudate at the pupillary border with oval-shaped 3 by 2 millimeter creamy material at the 8 o'clock, and the media fundus image was like that. While surprisingly, at the third postoperative month, the retina showed flattening without any complication documented by FAV, and the octa demonstrated flat retina. The superficial layer showed low vascular density, irrespective to the capillary density. Capillary perfusion was much more higher than the vascular density. ERG demonstrated good uh, good recovery of the retinal layer in comparison to the standard pars-plana vitrectomy when ERG shows lower amplitudes. So outcome. Clinical infection control achieved, progressive cleaning of media opacity achieved, anatomical stabilization, functional recovery exceeded, and expectation is given initial severity. This was undertaken as a last resort salvage strategy, not routine practice. Advantages: ultra povidone iodine, it is ultra broad spectrum antimicrobial, rapid onset of action. We don't need any cultural sensitivity. It is available and low cost. Conceptually useful when infection progresses despite repeated intravitreal antibiotics. Organisms are unknown, resistant, or mixed. Limitations and safety consideration. Experimental models show functional and histologic damage with intraocular iodine exposure. Published clinical experience supports diluted intraocular concentration, not 10%. These are case reports and small case series. Lack of randomized comparative trial should be framed strictly as exceptional off-label rescue therapy in otherwise unsalvaged eyes. Take-home message: unresponsive endophthalmitis remains a therapeutic challenge even in the era of early pars-plana vitrectomy. Povidone iodine has emerging supportive evidence as an intraocular adjunct when used in diluted concentration. High concentration intraocular exposure may be considered only as a salvage maneuver with with acknowledgement of toxicity risk, immediate irrigation, careful patient selection. Further controlled studies are required to define safe intraocular dosing protocol. And thank you.
Thank you.